Dr. Beth Bell is going to start off. She's from the CDC, and her job is to run the center that looks at zoonotic diseases and emerging diseases. She's going to tell us a little bit about her work. All four panelists are going to go through a fairly quick presentation of about 6, 7, 8 minutes, and then we're going to open up for Q&A. So hopefully you'll be able to pull out of their presentation some great questions to offer them afterwards. Dr. Bell.
As Todd was just saying, the threat posed by emerging and re-emerging infectious diseases is very real. And on this slide are just a few of some of the more notable infectious diseases that have emerged and re-emerged around the globe over the last couple of decades, with increasing international travel, global trade, migration of populations worldwide. Infectious diseases have the potential to spread faster than ever before, narrowing this gap between what's domestic and what's global. Rapid, accurate diagnostic tests are pivotal in our ability to keep ahead of all of these microbes, to detect and respond quickly to outbreaks, to figure out how the microbes are being spread so that we can stop it, and to take care of patients properly. CDC scientists, often working with partners in the private sector and in the public sector, aim to create faster, more accurate, and simple to use diagnostic tests, and also to improve the performance of existing diagnostic tests. On this slide, I'm just going to talk to you about a couple of tests that we've recently developed and are now using in the field. So this is a CDC investigator working with laboratory technicians in the Marshall Islands, where there was an outbreak of dengue. Dengue is an infection which affects up to 400 million people around the globe every year. These folks are preparing to use a CDC-developed assay which detects all 4 types of dengue virus and is actually the only FDA-approved molecular diagnostic for dengue. Since we first made this test available in July of 2012, we've shipped this to 36 states and to 71 labs in 48 countries. And this is actually an example of an assay where we think there may be some broad clinical applicability, and we are quite interested in working with a partner in industry going forward. The other assay I want to talk about on this slide is monkeypox, and this is a photo of one of my staff in working with the laboratory staff in the National Laboratory in the Democratic Republic of Congo, learning to use a test for monkeypox, which we developed in partnership with Cepheid and BioGX. Similar to the GeneXpert platform, actually. The National Lab in Kinshasa actually has had this assay since 2012, and they recently used it to confirm an outbreak of monkeypox, a rapidly accelerating outbreak of monkeypox in one district in DRC, which has already killed 8 people. And a team from my center left for the DRC last weekend to help them investigate this outbreak. So in the next few minutes, I'm going to take a little bit of more time to share 3 stories about some of our diagnostics work, meant to highlight 3 areas: discovering new pathogens, bringing tests to the bedside, and stopping an outbreak in its tracks. So my first story begins with in Missouri, where 2 men in different locations were hospitalized with a mysterious flu-like illness. And I'll say that many emerging infections start with a story like this, an unusual illness or a cluster of illnesses that doesn't turn out to be what the doctors actually thought it was going to be. And in this case, the doctors thought that this was going to be ehrlichiosis, which is a disease carried by ticks, but in fact those tests were negative. And so what happened next illustrates how we discover and how we learn about emerging infectious diseases. So first, we use various methods to identify what is causing the infection. And each year we discover at least a couple new microbes in exactly this way. And then we ramp up the diagnostics, often in collaboration with partners, to find additional cases, to understand how the disease is being transmitted so we can figure out how to prevent it. In this situation, we used next-generation sequencing and bioinformatics to find that these 2 men were infected with a never-before-seen phlebivirus, which is called the Heartland virus. Then we went to the field with our nets to drag up a whole bunch of ticks. We brought them back to the laboratory and eventually discovered or decided that the Lone Star tick is the likely vehicle for this virus. And now we're sort of in the next phase where we've developed a number of diagnostics so that we can actually understand a little bit more about how big a problem is this, how is this being spread, and what do we need to do about it. My second story comes from some work that we're doing in Uganda, which, as many of you know, is a hot zone for emerging infectious diseases. One of those diseases is plague, which is a potentially fatal infection that many of you may be surprised to hear didn't go away in the 15th century. But actually, plague, while not a common problem in the United States and many parts of the world, is actually a big problem in parts of Africa. It used to be that the clinical diagnosis of plague was, or that the diagnosis of plague was really more or less impossible in resource-poor centers. You'd have to get a specimen, you'd have to take it away to a laboratory, you'd wait for 2 or 3 weeks, and by that time, the patient has lost the opportunity to be treated with life-saving treatments. So what we've done over the last few years is work with colleagues to develop and field test a rapid, affordable diagnostic tool, which is the plague dipstick. The test is easy to use. It delivers results in 15 minutes. It is affordable, costs less than $1 per test, and it doesn't require refrigeration or electricity. Last year, I traveled to Uganda and visited our plague field station in Arua, which is in the northwestern part of Uganda where plague is endemic. On this photo over there on the bottom right, where you can probably recognize my gray hair, I sort of got a firsthand account from the gentleman in the blue shirt in that photo, who's a farmer who had symptoms of plague in October of 2012. He was taken to the local clinic on the back of a motorbike. They had our rapid test at the clinic. They tested him, and within 15 minutes learned that he had plague. He was treated with antibiotics. He fully recovered, and he was back working in his fields within 3 days. And I will say that this is an example of a growing number of people around the Arua area where plague is a big problem, whose lives have been saved partially because of our ability to use this assay to diagnose plague. And so this is an example of bringing the laboratory to the bedside, and we are sort of looking to use this technology for other pathogens like yellow fever, for example. So my third example, so imagine you go to the doctor, you've got a backache, and you're going to get a routine shot to hopefully improve your backache, and instead you find yourself in the period of a couple of weeks in the hospital fighting for your life. That's what happened to hundreds of people here in the United States in late 2012 when a contaminated steroid medication from a compounding pharmacy in New England was to blame for a deadly outbreak that killed 64 people and made about 700 people sick. A key challenge in this outbreak was that the fungus causing the infection was extremely rare. We really had only recognized it once in one very small outbreak previously. So we really didn't have much in the way of tools. And certainly in terms of diagnosis, the doctors were having to wait for culture. That takes several weeks. And in the meantime, there was a lot of confusion about who had this, who didn't have it. It was not only, it was affecting patients and also affecting our ability to figure out what we needed to do because we didn't know who was sick. And so our laboratory at CDC developed a PCR-based assay which allowed us to make this diagnosis in a period of hours or days rather than weeks. And then we were able to test literally hundreds of specimens that arrived from doctors and hospitals and get the results back fast enough to really affect patient management. So as profoundly tragic as this outbreak was, what we did really did save lives, and the diagnostic played a pivotal role in that. So these are a few examples of stories about how CDC has used diagnostics successfully in the past. They are success stories, but they're past success stories, and we're really now at a crossroads at CDC. And I want to take my last minute to describe a CDC initiative designed really to bring the benefits of the 21st century technology to public health. The President's FY14 budget includes an initiative which we're calling Advanced Molecular Detection, or AMD. It's a $40 million a year initiative for 5 years. AMD combines the elements of classic epidemiology, of whole genome sequencing, and bioinformatics. And while I'm very proud to work at CDC, I have to honestly say that CDC is woefully behind in this area. The fungal meningitis outbreak I just talked about provides some examples of this. If we'd had access and were able to use these new technologies, we could have type strains and figure out who was getting sick from what, do resistance testing to make sure that doctors were giving the right medicines, and most importantly, possibly figure out what was in those vials. We had this laborious procedure taking weeks to culture to figure out what was in the vials. So AMD, which, as I say, we're hopeful we can get started in FY14, will help us to more accurately and rapidly diagnose infectious diseases, investigate and control outbreaks, understand disease transmission patterns, determine if an organism is resistant to drugs, and develop and target prevention measures so that they're more effective. And this initiative provides us also with an opportunity for a lot of collaboration. We certainly couldn't and really don't want to do this alone, and we're hopeful that with the support of our partners, we'll be able to realize the full potential of AMD for CDC and for all of public health. Thank you.